Our charge here today is to talk about complex elbow trauma and instability. Naturally, this often concentrates on the terrible triad, but there's a variety or a spectrum of injury that kind of can fall into this heading. So this is the panel that's already been introduced. So the rules of engagement, these are the modified Abood rules. So some of them, they're saying the information given is all I have. I'll give you what I got. But if you need more information, I don't have it, I'll make it up. So I can lie with the best of them. So really what we're talking about here are patterns of injury in the elbow. When we talk about complex instability, the classic ones are the terrible triad, and now probably in the last decade or so, we've recognized the varus posterior medial rotatory pattern, but really this represents, and this is somewhere where I think we can improve in terms of nomenclature and how we look at these, but I look at them as dislocations, subluxations, and then disruptions, and they're all complex injuries, and they all have certainly downstream effects on function and stability, but they're all along, I think, a relative spectrum, but we'll concentrate on the terrible triad, and we'll introduce some of these other patterns. So the first case, 51-year-old gentleman, fell from a ladder 5 feet. He was painting hit the trim at the ceiling of his house, fell onto an outstretched arm, unable to move the elbow, presents to the ER for evaluation. So initial assessment, what do you guys look for, anybody, when you first evaluate kind of the elbow, before you even get x-rays or any of that, or are x-rays the first thing you get? We're going to save the big questions for Dr. Mori, so we'll start. Joaquin, why don't you, how do you assess a traumatic injury to the elbow?
So I think depending on the situation, if the elbow is clearly dislocated, I think I may get an x-ray almost right away. If it's not that clear, then I will try to assess the elbow itself in terms of, point of tenderness and deformity and so on. I think it's also important not to forget to assess the forearm and the wrist. So that will be important also, just early on, make sure that the patient does or does not have wrist pain and forearm pain. I also want to know what's going on with his ulnar nerve, because I think there is a pretty high rate of ulnar neuropathy at follow-up in patients that already have neuropathy at presentation. And oftentimes we fail to document that, and I think that's important, especially if you have a patient with a distal humerus fracture. You want to document in the chart what's going on with the ulnar nerve and other nerves. Okay, great. So he presents, he's obviously limited in his motion. His pain is the predominant reason he's not moving it, but he's got limitation. Skin's intact, he's swollen for sure. He's neurovascularly intact. So, yes.
Can I make just a comment about the very first assessment? When I see a patient like this, the first thing I look for, everything Joaquin said is very appropriate. I do a very gentle exam of the wrist. If they're not hurting, I still examine it because of subtle injury. But it's how much swelling do they have and how long has it been since the injury? That's hugely important because it tells you what the soft tissue extent is, at least to some extent. It tells you what you can prepare for, because as you all know, what you're seeing on an image is a recoil. So I look for the amount of swelling and the duration of injury to when I'm seeing them.
Does that affect your timing in terms of surgery? Let's, for argument's sake, say the elbow's dislocated, you can reduce it, but their soft tissues are very swollen, edematous. Do you hold them sometimes and wait, or do you believe there's an early and a delayed window that you can get these done?
Well, if it's ordinarily when you see that much swelling, it means, as I said, it's a lot of soft tissue disruption, and so I try to get it anatomically reduced quickly. The other thing is the one kind of dislocation that you can pop back in quickly that may be associated with a moderate amount of swelling is a perch dislocation.
Yeah.
And that doesn't take much effort. The longer you wait, the joint's going to fill with a hematoma, and it could be somewhat more difficult. So I try to get them anatomically as soon as I can.
Okay, great. So start with some x-rays. So this is the initial injury film. Comments on this? Paul?
Yeah, so I think you're seeing an injury to the coronoid tip there, the radial head. I don't see a big extension into the coronoid, at least in this image, but after the reduction, I would get a CT.
So how do you know, just looking at an x-ray, how do you know you have a coronoid fracture and not just a radial head fracture with this?
So I think on this, you can see the tip of the coronoid there has been sheared off by the dislocation. Occasionally it's blocked depending on the view and your rotation with the x-ray. And so sometimes you actually need to get a good reduction film before you're going to be able to assess that.
So my general rule in what I teach is that if you have a dislocation associated with a fracture, it's your obligation to prove you don't have a coronoid injury. So successful reduction, is that enough for you guys to decision make, or are there additional imaging studies that you, in specific cases or routinely, will do for these kinds of injuries?
The only case would be if the patient has symptoms in the forearm or the wrist. I may get bilateral wrist x-rays, just to make sure.
This guy, his forearm and wrist are fine, shoulder's fine, as in a very limited exam, but distally and proximally, he's okay. This is not a board examination, Joaquin. You can ignore the wrist and the shoulder a little bit. I won't penalize you. I'm not going to throw you out and make you come back next year. Any other studies after reduction? So we do reduce. This was reduced. It was stable after reduction. Anything else do you routinely do? Any advanced imaging?
Yeah, CT scan.
Yeah. Okay. How many people routinely for this injury pattern get a CAT scan before or after reduction? Most often after. Okay. What value does that hold? Lisa, what does CT give you, particularly three-dimensional CT, that an X-ray doesn't? I mean, why do we do it? I mean, if you know you have a fracture, dislocation, and let's say a post-reduction X-ray tells you have a radial head and a coronoid, what is the value or added value of advanced imaging?
I think it helps for a couple things. The most important thing is the medial aspect of the coronoid. So as we've gone forward, we've realized that little portion of the bone is really important for stability, and if there are even small fractures, those can rapidly go on to arthritis, sometimes even if you fix them, but I think at least it gives you an idea that, and you know that you have that, you have injury on that medial side, and on a lateral x-ray, which is what we typically look at, to see if it's concentrically reduced, you can miss that. The other thing is sometimes there are some loose bodies in the joint, and it also helps to really define the anatomy of the radial head fracture.
So it helps in preoperative planning, essentially. Surgical approach, preoperative planning. Okay, so pattern of injury, we know he has a radial head fracture, coronoid fracture. What about soft tissues? Who believes that in a fracture dislocation you can have an isolated injury of the lateral side and the medial side is intact?
Theoretically.
Well, yeah, we're in the real world here.
Well, we've reproduced that in the lab, actually, but in the studies that have gone and actually looked at the injuries, there's always an injury to some extent. It may not be a complete disruption, but there's always an injury to both collaterals with this degree of displacement.
Correct. So I'm a firm believer that you don't have this injury pattern without a medial-sided injury, for sure. Now, whether you have to do anything about it, that'll remain to be seen. So how do you address this? We'll go to you, Dr. Mori. We're going to go to the Jedi Master here.
Sure. Well, the radial head is badly comminuted, and so that has to be addressed. The one thing we know is that there's a really good paper out of Madrid just in the last year that demonstrates clearly, I think, that with about a 92% success rate, that some relatively large type 2 fractures can be treated non-operatively. But it depends on the nature of that fracture and really what is going on with the radial head. And in our experience, if the radial capitellar joint has an instability either because of the fracture or you've resected it, the coronoid does not do well. So you have to address the radial head as part of your strategy, and with this degree of comminution, it call for a replacement. And then there's emerging data that shows that not all coronary fractures have to be fixed, and studies from our lab suggest that if there is a radial head present or reconstituted, then the real key is checking the kind of the rotatory instability, and the one that's the most at risk, of course, is the medial side. So I'd study the CT and make sure I understood the size and kind of morphology of the coronoid lesion to determine whether or not it needed fixing. On the table, you put the radial head in and then you study it. And if the ulnar humeral joint is stable to down to about 30 degrees of extension, I would probably finesse it because it's going to scar in and be stable. If it's not stable at that point, then it'll need to be fixed. In my opinion, if that's the case, you can fix it through the lateral side before you put the radial head implant in, oftentimes.
Do you make that assessment before or after you fix or provisionally fix the lateral soft tissues?
The final decision is after you provisionally fix it.
Okay, great. So this is, you can explain this too, Dr. Morey. So this comes out of Mayo, and we all who do this know this, but explain to us what this kind of really says.
Well, this is just a kind of a conceptual way of looking at elbow stability, and the real key to elbow stability is the ulnar humeral joint, and I think that's pretty well recognized at this time. And then if you look carefully at the anatomy, the medial and lateral collateral ligaments are like guy wires. They come off, both of them come off right at the axis of rotation, as you might imagine. And they insert almost parallel or transversely on the ulna. One of them the sublime tubercle, the other is the tubercle Christus supinatoris. And so they serve as guide wires. And if you have those ligaments intact and an intact ulnar humeral joint, you can easily get by without the radial head. But secondarily, if the radial head is not intact, then you have to make very sure that the ulnar humeral joint is stable. And if it's not stable due to the fracture pattern, you got to render it stable with fixation.
Okay, great. The surgical approach, how are you going to approach this, Russ?
Well, I would make a lateral incision. I mean, I used to do a direct posterior, but the flaps can be pretty big, so I would actually do a Coker incision laterally, and it does not need to be a very big incision for this particular case. And I would address pathology from medial to lateral, closing the ligament last as I'm going out, depending on what I see with the coronoid.
So does the decision on a medial approach, is that an intraoperative decision based on what you're doing with the radial head and what you need to do with the coronoid, or?
I probably know ahead of time with the CT scan, and even if I needed to go medially, I'd probably make a small medial incision and a small lateral rather than one big posterior incision, quite frankly. So.
Okay, so Extensile Coker, this is often what you see. This is out of a JBJS article, but you'll often, once you get through the fascial interval, Coker's interval, you just get into this huge soft tissue defect. It's what they call the bald epicondyle. You can assess your fracture through this. Fracture management, in this case, we replace the radial head. Since we were replacing the radial head, you can access the coronoid through that defect, and then on the way out, repaired. Any ulnar collateral ligament, anybody gonna, well, we already talked about that. I did not fix the ulnar collateral in this case. Okay, aftercare. Caroline, you're up. So how do we manage these post-operatively? Early post-operatively, late? We'll talk to the surgeons first about how do you immobilize these folks post-operatively? Do you just put them in a sling? Do you splint them? What's your early post-op care after an initial post-operative period as well? Paul?
So I usually will splint them for about 1 to 2 weeks. Most people come back somewhere around that 7 to 10 day mark. After that, we'll try to get them moving. And I think the key is they have a good physical therapist. At least where I'm in practice, there's quite a few physical therapists, and it's sometimes hard to get them in with someone who you know and trust. And so I sort of impart that on to them, that it's good to have a person who is going to see them, is going to actually get their arm moving, and will take them through a good passive and an active assisted range of motion.
So how do you protect? I mean, the most concerning thing early, obviously, is, for me at least, protecting, one, my soft tissue envelope and my lateral-sided soft tissue repair. Is there anything you do special about that, or are there any instructions you give? It's not an overstuffed radial head. Here we go. I know it was one of you guys. Fuckers. Anything you do specifically? Do you continue with the resting splint for a period of time afterwards? Do you brace them or anything along those lines? Or do you just let them fly and put them in a sling?
No, I usually use a brace. I think most people tolerate it.
Okay, great.
Matt, can I make a comment?
Yeah,
I think a problem that I see sometimes after surgery is not immobilizing the airway enough flexion. I think that's important because if your soft tissue repair is suboptimal, which can happen, having the elbow in flexion is really protective. So I think it's important. Sometimes I see post-op x-rays where the elbow is in maybe 40 degrees or 60 degrees. I want to go to 90. I think that's important.
into flexion, you mean?
Yes.
Yeah, of course. Anybody prophylaxis, HO prophylaxis? Okay. Yeah,
One of the things that I try to do is, before you've even fixed it, put the patient through an arc of motion and find the arc at which it becomes unstable. That gives you an idea of where it should be stable after you've fixed it because it's unstable with the fracture down. If you're not sure of your fixation, there's tremendous forces to go through the elbow, even passively. And you fix your lateral collateral because it was a bald eagle. So I typically will use an external fixator to stabilize everything for 3 or 4 weeks. And then when I take the X-fix off, they're asleep, I kind of stretch them out a little bit. Or now with the new internal fixator, you can consider that. If you're worried, again, if you're worried about how secure your coronoid fixation is particularly.
and what's is that a routine, or is that just if they're demonstrating instability towards end range? Is there a limit to that?
Yeah, if you've got if an ulnar humeral joint with the fracture non-fixed is stable through an arc of about 60 degrees or so, then you've got a lot of range to where you can fix it and not need to do anything else because it's a stable elbow.
Gotcha.
But if it tends to be unstable, you know, even like Joaquin says, it's almost always stable as you flex them up, but you have to get them way flexed before you see that stability. That's one that I would stabilize with the next fix.
And how long does that stay on for? You said about 3
3
weeks?
to 4 weeks. If you leave them on longer, we've got data that shows they do get into pin problems. We looked up our experience with X-fixes, and I did not have a ring sequestra ever, but I almost always take them off at 3 weeks. So
Lisa?
it's-
Matt, I'd leave mine immobilized a little bit longer, just, over time I've realized that if it's stable and I don't need an X-fix, I don't mind leaving them immobilized for about 3 weeks, and that's about my sweet spot where I start moving them, because I just, the worst is stiff and unstable, so if I have it stable, I can deal with stiff.
Okay, got it. Yeah, stiff and unstable is bad. All right, so
And that does happen.
Yeah. So how do we go about getting them moving? Caroline, you're on now. How do we, when we kind of give you the green light, it's time to go, how do you do it? How do you perform this? Or do we do this with the patient supine? Do we do it with them seated? What are your markers for kind of how you go about this?
Definitely. So I think clearly understanding what happened in surgery and what was fixed, what was reduced, and the specific limitations for how, immobilization, et cetera, is obviously really important. And once we can get them moving, I find that supine is often a nice place to start. Patients feel comfortable and supported. You can get their scapula and the rest of their, thorax in a nice position and their arms supported, initially for passive range of motion and soft tissue work. But quickly moving a patient to sitting and enabling them to work on active assisted range of motion there, and even, eventually into standing positions. I find, especially for range of motion, it's very helpful to enable body weight to kind of get range of motion in either sitting and then, standing positions, of course. So really, I think starting supine is probably where I would for a patient like this, and progress them into, more functional positions.
Is there anybody in the audience who doesn't use OT or PT postoperatively in this group of patients at some point? I knew you were going to put, I was a setup, by the way. So how do you manage your patients? Because there's a case here, if we get to it, that shows that patients can do bad things if you're not very careful in instructing them.
Well, first of all, the reason that I typically don't is how many therapists do we have? Like 100? And you never know who you're going to get. And if a person doesn't understand the elbow, they can do more harm than good. And remember, if you write a prescription and saying, please get motion to a therapist, what's the therapist going to do? They're going to get motion. And then they'll record the motion. The patient goes home and swells up, gets sore and stiff, and starts losing. As you know, my attitude toward that. So I typically use a adjustable brace and become my own therapist. If I had the luxury of having somebody that I'd work with and kind of trained, that was my therapist, so to speak, I would change my philosophy.
Surprised the Mayo Clinic hasn't, well, you're not there anymore, but they haven't figured that out. Come on. I guess all right. So this is just something I do early for my patients. I think supine overhead movement is very protective of the joint, and they can do this either formally with a therapist or on their own early on. Okay, case 2, 36-year-old, tackled playing rugby. His arm was caught awkwardly in a pile, so the scrum got him. He had deformity of the elbow, couldn't move it, and shows up in the ER. We've gone through some of this stuff already, but specific on this one, he's neuro intact, but vascular exam shows a diminished pulse, radial pulse. And these are his x-rays. By the way, he does have a present pulse, it's just diminished. So anything specific here? Any more urgency maybe to getting him reduced? So get him reduced.
Median nerves intact?
Median's intact, believe it or not. So this is reduction, and with reduction, his pulse returns. A little hard to see, kind of the injury pattern. So advanced imaging here. Anything different on this one? Describe somebody, Lisa, describe the injury pattern.
Well, there's a fragment from the radial head. There's fragment anteriorly, and I'm assuming that's the radial head fragment. The coronoid looks okay on the medial side, but that proximal fragment is probably the tip of the coronoid.
Okay.
In fact, it is. I know it is.
And what does that tell you, too? Dr. Morey talked about it. The location of these fragments, where they often end up sitting, is where their displacement occurred to. So a radial head fragment posteriorly would tell you that's where the radial head once lived. It doesn't fracture and then float that way. It was fractured and ended up there because that's where you were displaced. So surgery, where are you going to fix it? What are we doing here? Fixing it or? Yes, because we're surgeons? Okay. All right. So this was one that I did the same metric but didn't do anything to the coronoid. Radial head replacement, lateral sided repair. So just a little variation that this is more of a dislocation with a radial head fracture, not a small little coronoid fracture.
Matt, one thing to notice, if you look at the original film, did you notice how the distal humerus was further distal?
Yeah.
And so that tells you more stripping probably relates to the diminished pulse. The others, if you look carefully, I have that rule of 30. If you draw a line between the tip of the coronoid and the tip of the olecranon, if it diverges going towards the wrist, that's a potentially stable onohumeral joint. If it's parallel or converges towards the wrist, usually the coronoid fracture is so big it'll definitely have to be fixed.
So just to show you what he's talking about is if you draw a line here and a line between the tip of the olecranon and the base of your coronoid fracture, if that line is divergent distally from the subcutaneous border, you probably have enough coronoid, provided the medial side isn't involved, that joint will be stable without fixing the coronoid.
Right. The other thing to mention is when you see this much displacement, you know it probably displaced further, as we mentioned earlier. That good of an ulna also can make it more difficult to reduce. So be aware of that. If it reduces real easily, you usually have a pretty big coronoid fracture.
Or a pretty big soft tissue injury.
Yeah.
Or both.
Or both.
Yeah.
Yeah.
Matt, did you go to the OR with the intention of replacing it, or did you contemplate fixing it?
I mean, I'm more of a radial head slayer than I am a fixer. Now, part of my kind of bias when I fix radial heads has been that early in my experience, titanium radial head plates were the rage, and I could never get that to work. There's so much scarring to the titanium. They all lost forearm rotation. So for me, maybe we can open it to the panel. If I have an intact segment of the radial head, so it's a marginal radial head fracture, even if it's comminuted, I will fix to that. If I don't, if there's neck separation, I am not fixing those. I'm throwing them away and I'm putting a radial head in. And the question always comes up is, what's the consequence of a radial head replacement in young or older people? And my answer always to that is it depends on how well you put it in and how well you size it. The comment that I overstuff radial heads is actually untrue. And if anything, I undersize radial heads.
Being in
actually.
Washington, it is fake news.
I'm very sensitive. Don't criticize me. I cry easily. So I have a very low threshold, and quite frankly, I view a radial head too as a spacer. It can be a temporary spacer that you can put it in, stabilize the medial side, allow it to heal, and then if it's an issue later and you've done a good job, you can take it out. And I've never had to do that, actually, honestly. All right, so we did that one already. Okay, all right. So this is a 19-year-old senior from Villanova. He was skateboarding. This is 4 weeks before graduation, so right now he's in the midst of finals. He falls. He's unable to initially move the elbow. He kind of self-splinted his elbow for about 24 hours. His range of motion improved, but he continued to have soreness for many days, and that's when he presented. So 1 week post-injury, he presents to the office. He has slightly limited range of motion. End range is a little bit limited, both in flexion and extension. Has fairly reasonable pronation and supination. His joint is stable. He's neuro intact. And these are his radiographs.
Did he have pain with those arcs, specifically rotation?
He did at the end range, but not through mid-range initially. So when you get him kind of to the end range and you try to kind of give him a little overpressure at end range, he was uncomfortable, but it was pretty reasonable movement. I mean, he was sore, but it wasn't unduly painful. So any comments? Would you get more imaging, or can you comment based on what you have about where we are?
Well, you see two things. You see the two loose fragments. So he could have subluxed and slipped back with the way you've described it. But if you look at the head and the neck, it looks like he is wedged, has a wedge fracture, a partial compression fracture of the neck.
So that's a great point to point it out. Like, you get compression here, so what looks like it's just a marginal radial head fracture actually may be more than that. You may have impaction kind of here in an angular deformity. In that situation, would you expect to see more loss of motion because the geometry of the joint, or can you still have pretty good motion with slight angular deformity of the radial head?
Yeah, it takes over 20 degrees to start seeing very much with the nature of that joint. And if his articular surface hasn't been damaged, that's why he didn't hurt too much through the mid-range. And why it did hurt near at 60 degrees.
Yeah.
Because you're stressing the fracture.
All right.
The other thing is the location of those loose fragments. That proximal one is classic for the tip. The head usually doesn't go up that high.
Correct.
And the other fragment you see is off the neck of the radius.
So it's this fragment. This is typically coronoid.
He did a partial subluxation, then spontaneously
So like a little
reduced
type 1.
Yeah.
coronoid.
It's just a marker that says, here's what happened.
I don't have 3Ds here, but this is kind of selective cuts of his injury. So, sorry, let me go back. So radial head, obviously marginal radial head, but maybe some impaction here. It looks like it's pointing in the right direction here, and maybe here too, but there's more of a anteromedial radial head and a small coronoid fragment. So what are we going to do with this? We're going to fix this, or are we going to leave it?
I'd watch him very carefully. He's someone I would see kind of on a weekly basis for a couple of weeks, make sure that he's concentrically reduced radiographically. As I probably wouldn't put him in therapy initially either. I would just give him some basic instructions, neutral rotation, assisted flexion extension, and then he could work on pronation supination in a sling at 90 degrees, but not pronation supination out of the sling. And I would watch him very carefully, but probably not fixing him.
Okay, so we have both elected to treat. He was graduating. There was no way he was going to have surgery on his elbow with what he did. So we did exactly that. We were trying to maintain what he had. And this is how he presents. He was seen 2 weeks later and then 2 weeks after that, so 5 weeks post-injury. Flexion extension arc isn't bad. He's lost a little bit at end range, not a lot. And he's losing pronation and supination. Still stable. And now he's got pain throughout and a very rigid endpoint. Before it was a soft endpoint.
Did you say he has pain through the arc?
Pain with a pronation supination arc. Flexion extension, he's fine.
Right, but it's not at the extremes, it's through the arc.
No, it's through the arc now, too.
He needs to read the textbooks. It's not supposed to hurt.
Well, it does. So this is a follow-up CT scan with 3D reconstructions now. Thoughts, Lisa?
Yeah, I think that the fragment of the radial head is in a location that's could be a mechanical block to motion, and certainly, almost certainly will be if it heals solidly there. So I'm worried about that.
Me too. So what now?
He's a young guy. I probably would go in there and either excise it or see if it needs to be fixed, but I would get it out of there.
How would you do it?
I would start with a scope, because I think if you're just going to, we're not as worried about stability here. He seems concentrically reduced, so I would probably start with a scope and see if I can get it out that way.
Okay, did that. So one of Sean's tenets in arthroscopy is you need to be able to define the capsule as a distinct structure if you're going to work outside of the capsule, and that was not possible. That fragment was outside the joint, and there was a lot of scarring right at the interval, but along that kind of mid portion of the radial head medially. So I was not comfortable in that scenario. If I could have separated the capsule from the underlying or the overlying brachialis and brachioradialis, I would have done it arthroscopically, but I couldn't. So we opened him.
So you took a look with a scope first?
Yeah.
Yeah.
Yeah, and bailed reasonably quickly, and got the fragment out. It did reef his lateral side because he was a little lax afterwards. I didn't reconstruct it. I more just kind of cinched it a little bit, and he's done well at this point. So splinted him, hinged brace just to protect the lateral side for me, and then allowed him full pronation, supination, limited for about 6 weeks, and then progressed. And this is where he is at 3 months. Okay.
Can I ask a question?
Yeah, sure.
If you had elected to go in there acutely
Yep.
and saw the fracture fragment and saw that that neck was compressed somewhat, what would you have done?
So I elevate it and see what I have. If it's not bad, in a young person, it's not usually as bad. You can elevate it and maybe graft underneath it. Mm-hmm. You'll know how much you have to elevate it based on your fracture fragment, because
Right.
it won't key in anatomically
Exactly.
unless you raise it. And if you can raise it up, graft it in a young person, that's one I would probably fix. The problem I've had is with folks who are a little on the older side. When they get that compression and you elevate it, there's just an enormous cavitary defect. And I have not had good luck bone grafting them, plating them, and had that go on to anything but a non-union.
What I was really going to try to bring out is the point that you made earlier is putting a plate on the radial head and neck is something I avoid like the plague. Because as you said, they scar like a mama. And that the article from Japan that showed 90+% good results also had to go in and take them out in 92% of the patients. So if you put a plate on, plan a second operation, because they get dramatically limited motion, and it typically can be painful because there's a lot of scar around it. So that was what.
Do you think that the newer plating systems, like the
It depends on the mama.
mama scars any way she wants to is the answer to that question. Do you think the newer generation stainless plates are better in terms of scarring to the plate? You know, my problem with the newer generations ones is they tend to be bulkier. They look much thicker.
Yes, what we were trying to design once was a very low profile plate, but we also use these cross pins or screws from the margin of the head if we have a neck we're trying to stabilize. But like you said, if you have to correct the angulation on an older person, it's pretty tricky, really. In a younger person, they're a little more pliable. But I would try to use a low-profile stainless steel plate.
Okay, great.
If I was doing it.
Okay, 43-year-old fall, painful. He has transient ulnar nerve paresthesias. They go away within 10 or 15 minutes. Again, he's limited by pain. He shows up in our urgent care for evaluation. Obviously, painful motion. He's swollen. He's neuro-intact at the time of evaluation. X-rays are here. Joaquin, we haven't heard from you in a little while.
Yeah, this worries me for that pattern that you mentioned of varus posteromedial rotatory instability. So the lateral joint line space is open a little bit, and then both on the AP and lateral, you can see changes on the medial aspect of the ulnohumeral joint. So this
Is there anything on the lateral? This isn't a perfect lateral, but is there anything on the lateral that, I mean, there's a couple of things. One that's much more obvious.
Yeah, just anterior to the silhouette of the radial head, you can see a fragment that is displaced. And I don't see the ulnohumeral joint open clearly in this projection, but that could be the second thing.
Yeah, people will describe, although it's got to be a pretty good lateral to see it, is that the trochlea, or the medial trochlea, is rotated up into the fracture bed. So do you routinely CAT scan this varus
Yes.
posteromedial pattern?
Yes.
And why? What value does that have?
So the value is the extent of a fragment. Most studies have shown that if the fragment is smaller, under 5 millimeters, you may be able to get by without surgery. But if it's beyond 5 millimeters, then probably surgery is indicated.
And what about involvement of the medial facet?
Yeah, that's what I meant.
Yeah.
So the intermedial fragment, if it's more than 5 millimeters.
Oops, sorry.
So that's a pretty substantial coronary fracture. I would definitely fix that surgically.
So I think the important thing we're all kind of talking about, that's your sublime tubercle right there. Okay, so any of these fractures that come down into the medial facet, this is ligamentously unstable, but through the fracture, and your joint is kind of up into that fragment. So what do we do about this one? How do you approach this one?
I would do both a medial and a lateral exposure. I will go medially first, starting the ulna distally, and then get my exposure from distal to proximal, leaving the ulnar nerve inside, but doing a decompression, planning to do reduction and plating. And then on the lateral side, I think it's important to reattach the origin of the LCL, which is almost always avulsed.
Do you do the approach that Scott talks about, where you elevate the FCU and leave the flexor pronator attached?
Yes.
You do.
Yep.
All right. How much distal dissection does that require to get that?
You have to go probably 3 to 4 centimeters distal to the joint line medially, which I think is doable.
Yeah.
And just keep elevating all the muscles superior still until you can have enough exposure to place a neutralizing plate. You don't need to have a very long plate distally. You need maybe a couple of screws, maybe 3.
Yeah, I found that approach is great in cadavers, but in real people, it doesn't work as well. I usually
That's
end up
true.
I start kind of whittling my way up the flexor pronator mass until I get the look. You often can do it without taking the whole thing down, but I think seeing that and exposure through getting your exposure through a really limited approach can be challenging, particularly if it's swollen and edematous. So, you can start that way because that's the first step in any approach, and then expand, make it more extensile to take down. So the coronoid fracture medially and then coming laterally to fix it. And in this case, what I'll do on the lateral side, this is a suture anchor hole actually, is that, usually you can just repair the ligament, but if the ligament substance doesn't hold suture, then I'll often put a suture anchor and not reconstruct, but just use that as a solid base to just stent across the lateral side, and they scar in pretty well.
Did you move the nerve?
No, I don't. I lift the nerve out of the bed, but just put it back. Leave tissue underneath the nerve and just kind of elevate it. And you really need to elevate it just to get the distal part of the plate on, typically.
Hey, Matt, you ever use an internal brace for your lateral side?
I haven't until, I've done it on the medial side for an acute fracture. I haven't done it yet laterally, but I think it's a really attractive option for the lateral side. I mean, I use them now for ligament repairs in throwers and have had good luck with it. So I think that's just another form of a stent across the lateral side while everything scars in. If you do it through drill holes, though, then it's not quite as easy. But if you're going to repair your ligament using your internal brace, it works well.
Matt?
Yeah.
One thing I'd mention is this really looks good. Of all the things we've seen so far, this is the one lesion that if it isn't done right acutely and isn't done right, the reconstructions are really hard and typically don't work because they tend to get arthrosis of the medial humeral joint very rapidly, and there's not a good solution for that. So this is one of those fractures that you got to read properly and address it acutely. And if you do, you can get a very good result. If you miss it or don't operate on it initially, it's hard to salvage.
All right. So this is a variation on the theme. 26-year-old. I'll just do this quick and we'll get you out of here. We're going to run through this. Because otherwise we're going to be talking about my mama. And I don't know. This 26-year-old felt playing ultimate frisbee, same sort of kind of presentation. He was initially painful. He could move his elbow a bit. He was seen 2 weeks post-injury. Had some limitation in motion and rotation. Pain with a varus stress on the elbow. And his x-rays were this. Anything concerning? Anything obvious?
There seems to be a double contour of the medial coronoid again on the AP.
Yeah, well, I didn't see anything remarkable here, so ordered a CAT scan of his elbow, and this is his injury.
Got a little widening on the AP radiograph where that,
Very slight.
almost like a posterior wall, acetabular wall fracture where you don't see displacement, you see kind of compression of the bone instead.
So what would you do with it? Just to quickly, would anybody treat this non-operatively?
I might. It depends.
Well, I did, so. So he didn't want to have surgery. We followed him for pretty closely, and this is where he is at 3 months. So he's done pretty well. I mean, this is maybe a little concerning here, but his joint, I mean, I think that's more x-ray view than.
Do you think that's one where the lateral, because usually with the posterior medial rotatory,
Yeah,
the lateral side fails in tension?
Yep.
This one looks like the lateral structures are probably intact.
It's just
So
compression.
maybe a different.
Yeah, well,
Pure
this
compression.
is a different injury pattern, I think, because it doesn't involve the medial facet, so it's not probably truly a posteromedial.
Correct.
I mean,
Fracture is more transverse.
the way I look at these things is if you have, I think it's a combination of rotation and axial load, and if you have more rotation than axial load or more axial load than rotation, that drives your fracture pattern. I have others, but we're going to stop it here. Thank you, everybody. Great discussion.